management recommendations for the perinatal inpatient currently receiving buprenorphine or methadone. And we'll turn right over to Ms. Hickey.
Good afternoon, everyone. My team is in the back. They're supporting me from the back. Isn't that nice? Paula Adams-Witz is also in the back. We recognized about a year and a half ago we were seeing more of an influx of patients who were on buprenorphine and methadone. And the challenge was managing their pain during the intrapartum and postpartum periods. And what we realized very quickly is that pain management depended much on the provider's experience, their training, anecdotal cases, experiences, and we also recognized that patients' pain was often underestimated and undertreated, and that there was implicit bias when it came to this patient population. So we decided quickly, we realized that there was a knowledge gap, and we recognized that opioid-dependent pregnant patients are often hyperalgesic and require higher doses of opioids, and that was counterintuitive to many providers' experiences and what they recommended and prescribed. We knew that addiction caused neurophysical, behavioral, and social responses that often worsen pain. And it was really important for us as a whole team to leave our implicit bias at the door when we came in and build trust among us and our patients. So we went to the evidence. We decided to see what the evidence recommendations were for caring for these patients. So according to ACOG and the American Society of Addiction Medicine, we took away these recommendations. Pregnant women who are on buprenorphine or methadone must continue their maintenance treatment during the intrapartum and postpartum phases. Pain management should be managed as if they are not receiving buprenorphine or methadone at all. And recognition that the MAT does not provide any analgesia for these patients. Also, the evidence clearly stated these women often need higher doses of pain medicine to manage their pain. This was also very interesting. When I shared this with some of our physicians, it just makes a whole lot of sense, but I think you don't think about it. Often this patient population is also addicted to nicotine. And when we bring them into the hospital, they're not allowed to smoke. So that abrupt cessation of nicotine precipitates withdrawal, exacerbating their symptoms and makes them spiral, quite frankly. And they need more pain medicine. So just the awareness of, we often just need to think about putting a nicotine patch on these patients. The addition of NSAIDs to perioperative analgesia regimens reduces opioid requirements by up to 30%. And this was important for us, as I'm sure you all know, we are a baby-friendly designated hospital. So we needed to see what the evidence supported as far as breastfeeding. And it was very clear. Breastfeeding should be encouraged in women who are stable on their opioid agonists. They should be encouraged to breastfeed, provided they are not using illicit drugs and have no other contraindications. So this made us look at our postpartum pain management as well as our intrapartum management. There is consensus that these patients have opioid debt, and they must receive their daily doses that must continue. And you can further divide the daily dosing and perhaps add a little bit more if needed. For vaginal deliveries, typically NSAIDs with acetaminophen are sufficient to manage pain. And with cesarean delivery, and this is where we really had our biggest challenge, many of our physicians and anesthesia folks were just hesitant to use PCA. But in the literature, it was overwhelming consensus that these patients need PCA for pain management in the first 24 hours. And then NSAIDs with acetaminophen, oral Percocet, if needed, is indicated. They were very clear that these patients on buprenorphine methadone should never receive Stadol, Nubain, and Tolwyn. Important for us because we use Nubain and Stadol regularly. And then certainly caution with benzos. So what did this do for us? After we did the evidence-based review, we decided, okay, we need a power plan. We need a clear power plan pain management for patients on MAT during their intrapartum and postpartum phase and stay here with us. But then it also made us start thinking about our approaches to pain management with our general population. And that was quite interesting because we have given birth, pun intended, over the last month to a whole new delivery power plan and our approach to pain management with our general population. What we're doing now, we're using a lot of non-pharmacologic regimens, gum chewing immediately post-C-section, abdominal binders, post-C-section, scheduled Milocon. The literature is ubiquitous, saying that if you can address pain related to gas and distension, you'll do a whole lot better with decreasing your opioid use. And they also say that loading your patients pre-C-section with just PO Tylenol helps significantly. And then scheduling NSAIDs in our prior delivery power plan, we only gave NSAIDs PRN. But the literature overwhelmingly says schedule your NSAIDs and then Tylenol for mild pain with, and also reducing your Percocet dosages for moderate to severe pain. So this just went live for us a couple of weeks ago, and so far so good. We haven't had any major malfunctions, and I'll let you know what the downstream effects are. But that's it for me, short and sweet. Any questions?
Thank you very much. Appreciate it. All right, please, if you would, those of you who want to see me credit, please complete your evaluation forms, leave them at the table. I appreciate it. And our talk next Tuesday will be in cardiac amyloidosis. Dr. Hendel from Tulane will be here on that. So, thank you.